Second round, second session. Good afternoon, everyone. We'll start the second round of debates, the second table called How to Think About the New Horizons of Healthcare During Maternity, Experiences and Analysis at an international level. Thank you to all the speakers. The speakers are Helen Elden will do an introduction in due form, Salomé Álvarez and Aranzazu Villar. The first one will be Helen Elden. She's a professor in the Göteborg University, specializing in reproductive and perinatal health, and she's a leader of a research group in sexual, reproductive and perinatal health during pregnancy, birth and postpartum period. She's been part of different projects in Sweden, especially always based on sexual and reproductive rights. She's going to be presenting a part of her study in Sweden during this pandemic and post-pandemic times. So,
okay, thank you. I will start to tell you something about Sweden, because maybe you don't know so much. And thank you for inviting me to this webinar. Most women in Sweden give birth in the hospital. It's only about 10 out of 10,000 in Gothenburg that give birth at home. And most women are supported by a midwife. And the maternity care in Sweden is publicly funded and provided free of charge. At the antenatal clinics, pregnant women are cared for by midwives, and partners are welcome to join. If a complication arises during pregnancy, women are referred to an obstetrician who plan for their care. The standard program for routine prenatal follow-up consists of 4 visits up to pregnancy week 32, and thereafter 1 visit every other week until pregnancy week 41. And then the woman will come for a check-up and see if when to induce the labor. So if it's a primipara, we would like to induce the labor in 41 weeks and 3 days, but multiparas can wait until 41 weeks and 6 days. And after labor, the women and the baby stays at least 6 hours, and then they come back to the hospital for checkups, like the neonatal doctor and so on, breastfeeding. And there is also a postpartum checkup 6 to 12 weeks after childbirth at the antenatal unit. There were no difference in number of checkups during the pandemic, but the partners were not allowed to join at the antenatal care centers. They could be with the woman at the labor ward, but when the baby was born, they had to go home. And this was experienced with very frustration, and the partners also expressed being very sad as they had missed one of the most important moments in their lives. And we have submitted several papers on this that are probably published during the year, the effects on the women and the partners. But today I will share the screen now. Where is it? Yeah. Sure, I don't see it. Okay. Do you see it? Yes.
Yes.
Yeah, that's good. So this is a study that was done, and it was from the Institute of Maternal and Child Health in the VO Collaborating Center for Maternal and Child Health in Trieste, Italy. And it was published in Women and Birth. And the title is Large Gaps in the Quality of Healthcare Experienced by Swedish Mothers During the COVID-19 Pandemic. And it was a cross-sectional study based on WHO standards. As you know, the COVID-19 pandemic has imposed huge challenges on existing healthcare systems, and it has disrupted essential maternal and newborn services. And several studies have reported deteriorations in maternal and neonatal healthcare services during this pandemic. And reports of decreased use of antenatal services and increased maternal stress and anxiety have come even from high-income countries within the World Health Organization in the European region. Right. The WHO has emphasized the importance of quality of maternal and newborn care measures around the time of childbirth. And there is a questionnaire based on a key set of 40 measures that was developed based on standards for improving quality of maternity and newborn care in health facilities. And this questionnaire was validated and used for a survey in order to collect the viewpoints. And actually it was, I have to I can't see the, okay, now. I couldn't see the text. What happened now? Oh. Okay. So in this study, 21,000 women participated who gave birth during the pandemic across 12 countries in the WHO European region. The aim with the study was to report the findings from these 40 quality measures in women who gave birth in Sweden during the pandemic. And we also wanted to investigate changes in the quality of maternal and newborn care depending on various background and socioeconomic characteristics in these women. Eligible for this study were women at least 18 years of age who gave birth in Sweden from March 1st, 2020 up to the end of the data collection period, which was June 30, 2021. And they were asked to give voluntary consent to participate in an online anonymous survey. And this index, which I just told you about, evaluates 4 domains with 40 quality measures. You can give up to 10 points each. And the domains are provisions of care, experience of care, availability of human and physical resources, and key organizational changes related to the COVID-19 pandemic. Mothers were recruited through social media platforms, and they were recruited through Instagram swipe up links, which was administered by accounts run by the maternity wards of 2 university hospitals. It was Göteborg and in Skåne, with a large national following, or by parenting influencer accounts, as well as through Facebook links shared in parental groups. And more than 5,000 mothers were included in the analysis. Oh, you can't. Most of them were born in Sweden, as you can see. And most of them also had postgraduate university degree. 56% were primiparous, 93 or 94% were attended by midwives, but 29% of these were attended by midwives together with an obgyn doctor. And 1 of 5 women had a midwifery student with her. 75% had a spontaneous vaginal birth, and 7.4% had an instrumental vaginal birth, and that is vacuum extraction. 6% of the women had a pre-labor cesarean section. And here you can see the quality index, and you can see that women in Sweden were largely satisfied with the quality of maternal and newborn care, and they ranked high on this quality score, because the max is 400 points, and the mean was 313 points, and the standard deviations 52.9 points. The lowest maternal and newborn care standards were reported by women in Croatia, Romania, and Serbia, and the highest from women giving birth in France, Luxembourg, Spain, Sweden, and Germany. And this study clearly shows that there is room for improvement across all provincial domains of maternal healthcare services. Of these 5,000 women, 4,528 mothers underwent labor, and about 63% noted that the healthcare providers did not always use PPE in 2020, and that was because we had a lack of PPE, and also the standards was not strict from the beginning. But in 2021, it was only 8% of the women that noted that the healthcare providers did not always use PPE. And above 35% reported that they had no choice of birth position. 7.2% reported that they received no pain relief during labor. And about 1/3 narrated that they were not asked to consent when instrumental vaginal birth was performed, and that was vacuum extraction. About 22% experienced fundal pressure during instrumental vaginal birth, and 23% got no pain relief after emergency cesarean section. The quality of maternal and newborn care were significantly worse in women, in mothers with pre-labor cesarean section, and they were 475. 20% of them got no pain relief after the section. 19% experienced no roaming in with the baby, and 35% got no information about their newborn. And this is 16.6% versus 2.9% women with vaginal births experienced no skin-to-skin contact. 21% versus 7.5% experienced no early breastfeeding, and almost half of the women experienced inadequate breastfeeding support. 45% of them did not exclusively breastfeed at discharge from the hospital. About 26% versus 25% rated health workers' numbers as insufficient, and 40% versus 26.5% narrated no clear or effective communication during their childbirth experience. Many women, 42.9%, got no immediate attention when needed. and many women experienced no involvement in choices, and about 1/3 of them were not treated with dignity. 28% got emotional support, and about half of these women with pre-labor cesarean section observed poor ward reorganization. 60% experienced inadequate partner visiting hours, and about half of the women reported that they thought that there was an overall reduction in the quality of care provided. So the conclusion of this study is that we could find striking gaps over many key quality of maternal and newborn care measures, including the use of outdated practices and deviations from women-centered care. And women with pre-labor cesarean section, including emergency cesarean section, expressed lower quality scores across all domains, highlighting the importance of supporting this group in particular. And we think that this study adds to the previous evidence advocating for healthcare providers to use evidence-based practices to improve maternal and newborn healthcare services, even in high-income countries such as Sweden. And we think that these findings should be translated into appropriate health policies to improve maternal and newborn health services in Sweden and beyond. And regardless of the pandemic, policymakers at all levels in the health sectors are required to work together in order to ensure that all women receive the highest quality of evidence-based care. And I think that also you have said, maybe you have heard that we have a lack of midwives in Sweden. In every region in Sweden, we have too few midwives. And of course, this will also give effects on the care. So it was not only the pandemic, but the pandemic was the further increased the stress for the health workers and the mothers, I think. Thank you. So my presentation was rather short, but I can answer questions if you like to. Thank you.
Thank you very much, Helen, for your presentation. La segunda ponente de esta...
The second speaker for this round table is Salomé Álvarez. She's a midwife. She's the president of the Federation of Associations of Midwives in Spain, FAME. She's also a member of the Professional Association of Midwives of Asturias and works as a midwife in the University Hospital in Asturias, and lived through the pandemic as a midwife at the hospital beds, and also acts as such together with the other activities that she also does within the Professional Association of Midwives. Salomé Álvarez, you have the floor whenever you are ready. Okay, thank you very much for having invited me to this very interesting workday. What I've been listening to has been fascinating so far, and everything that I wanted to share with you has already been said. And in the end, I suppose this will help us have clearer concepts. We'll end up repeating ourselves, but we'll all lived through very similar circumstances. I was very happy to have listened to Helen, and unfortunately Sweden is going through the same circumstances, and that somehow is helping me deal with our situation in Spain. I'm going to now share my screen. And you are witnesses that they did work before for me, didn't it?
¿Se ha visto? A ver, espera.
You need to choose a file. We see your home page.
Sí, que lo había minimizado, ¿ves? Yo lo intenté, que me saliera bien a la primera, pero...
I did try for it to work fine the best time around, but there you go.
Vale. Lo hemos conseguido. Bueno, como hemos estado hablando...
As we've been discussing throughout the afternoon, what is obvious to all of us is that the pandemic was like a tsunami and provided a challenge professionally and at home. We have had to learn in an unthought of ways, and the resources that we've used so far haven't been enough to face such a worldwide challenge. We've had to improvise and learn along the way. And together with these, at the beginning of 2020 and towards the 2019, this was commented on, and the learning has changed our way of lives and has affected all of us at all levels, because on a personal level, we hold relationships in a different way, and our contact has also is also different. And whether preparing and thinking of having a child when a couple is thinking about that, and throughout pregnancy and bringing up a child has changed because of the pandemic and the way we live now after the pandemic. Marta has already mentioned that the pandemic has made for sexual and reproductive health of people has not become a priority and has come to a second best scenario. And as Marta said, everything that we had achieved as for maternity overnight disappeared off the scenes. Also, this created creation amongst professionals and also for the birth activists such as Donayum understand what this feeling is about. We all remember the first times when we were told about a pandemic that was going to overwhelm us, and that we didn't know what was to be expected. It was some uncertain times told about professionals, but also it had an effect on our personal lives. And we would like for people to understand what was happening. All of this was affecting us on a personal level, but also on a professional level. When you would get to work with a lot of stress, a lot of strain, and lots of changes that made us face work on in a different manner. I was forgetting about my presentation. Apologies. We had to relearn about the new workspaces to face these new circumstances within the hospitals, when we had to adapt the new spaces to intensive care units and also to COVID patients or COVID chosen help. And a lot of areas were closed down. In Catalonia, for example, a lot of these areas were closed down. In the Asturias areas, the maternity wards in the 8 that were open in the whole area, one was closed down to become an COVID intensive care unit at the beginning of the lockdown. This is the adapting to the new healthcare structures. As for the delivery rooms, had to also see 2 COVID patients, and we went from enjoying and fighting for the right type of births to a very cold way of attending them, and that provided a feeling that whether we liked it or not, we couldn't pass on our warmth to people, but we did so through a screen or through a facial screen or a screen, and that in turn caused panic and tension. I also heard Josefina say that through that study, wonderful study that they're doing, there are some studies from universities or researchers that point out the psychological variables as anxiety and worrying about the pregnancy, resilience, fear, loneliness contributed to worsen anxiety and depression amongst pregnant women. Also, what caused lockdown, especially that of spring 2020, together with having been in a hospital, may have contributed to women as very anxious and depressive times for women. Up till now, in a bigger or lesser manner, these women are worried about financial lack of support and professional lack of support. So therefore, this has caused a greater anxiety, a lot more than before. And in this way, midwives are a point of reference healthcare staff, and especially for the first pregnancies, first child pregnancy for women. The case wasn't possible for those pregnant women to talk about their fears, etc., and for the lack of trustworthiness because of the lack of visits allowed, and we all know that this wasn't the same.
Como el Ministerio de Sanidad en este
The
documento.
World Health Organization and the Ministry of Health, this is one of the last versions in 17 June 2020. This was the third, I think, of the versions that they issued. So the ministry collected together with a group of experts the evidence that we had on care to the pregnant woman and the newborn with COVID-19. In this document, there is a reference made to the fact that it should not be prohibited for women to be accompanied by their partners. It was a recommendation. And it was recommended not to prohibit to let the woman choose the person that wanted to accompany them, because as we know, this is one of the most important recommendations to have an adequate delivery if the woman is accompanied by a person that she of her choice. In this sense, the ministry said that as a general rule, visits should be restricted and should be restricted to just one person, probably the same, preferably the same person every time, and they have to be programmed in as much as possible. Ideally, or what was tried to do in many centers, is to allow one person to actually accompany the woman during the whole process, but this person had to do it and be confined. So if there was a positive result of the COVID test, then the person had to remain in the room with the woman. We have to take into account that many women and many families had other children or other person to care for. So many women had to went through the process alone, because although there was a recommendation to be accompanied by someone, they could not care for the rest of the family because of the strict confinement that they were imposed. It was also said that the other ways of communication should be used. For example, the video conferences. There were even some companies that had donated certain cellular phones, and this was an initiative that, although it was also used as a means of advertising for these companies, well, it was a good initiative because allowing these women to have contact with the rest of the family, that was something important for them because it gives them support. The ministry also said that the person that would accompany the woman had to be informed of the risk of transmission, tell him about the rules for confinement, and the partner had to follow a series of rules. Despite all these recommendations and despite all the rules that were included in recommendation and that had to be adapted to hospitals, what we saw is that the reality was that very often the accompaniment was not permitted in the case of women that were positive in COVID test. The excuse used is the possibility of contagion by professionals, by the partners, if they were positive in COVID test. So this means that the responsibility then was transferred to women. If we professionals had all the safety measures in place, we would not have risk contagion and would not have all these problems. And for us, that was a problem because we had to comply with the protocol, and very often we found ourselves in situations that actually made us have some arguments with families that did not understand the situation, which we ourselves did not understand very often. So these were times of high stress. Another of the measures that actually created a lot of anguish and anxiety with mothers was the separation of mothers and newborn babies, according to the WHO and the ministry, based on the evidence that we had at that time and even today. This was not justified at all. There was no scientific justification for this. It's the clinical situation of mothers. We were talking about mothers that were stable, that were asymptomatic, or that had very light symptoms. Then separation of the newborn and the mother was not justified. The recommendation in this sense was clear because it said that given the fact that there was no evidence of vertical transmission, then it was recommended to actually encourage women to breastfeed from the very beginning. I mean, if there was no medical condition by the mother that prevented this. Of course, each case had to be assessed individually depending on the clinical condition of the mother. Despite all this, despite the recommendations were clear, and we saw lots of separation of mothers and newborns. There were specific rooms for the newborn babies where they were kept in confinement. Mothers were in a COVID plant with no company, with no contact with the outside, without knowing what was the health condition of their babies. So this is something that we experienced just 2 years ago, and it was a very hard experience. And this also affected the follow-up of the pregnancy, because many of the visits that the medical consultations that take place for the follow-up of the pregnancy were done over the phone. You have to take into account that healthcare professionals that work with pregnant women were not, or at least were not at that time trained in order to have a telephone conversation with the mothers, because you need to follow a certain technique so that the few minutes you have available, you actually go straight to the different points that have to be tackled. So, of course, this meant that women felt very anxious as well because we before the COVID pandemic, there were a series of tests done on women, on pregnant women, and all these disappeared during the COVID pandemic. So they felt anxious about this. This also affected the prenatal classes because, of course, it was not possible to do it in an in-person groupal way. For a few months, they were suspended absolutely, and then there were certain midwives that used their own individual means and resources in order to prepare online classes for families that wanted to leave maternity and childbirth with as much preparation as possible. Another limitation had to do with the lack of training that the professionals had for this kind of activities, and also because of the lack of technical equipment, because many midwives did not even have a computer with an internet connection, a microphone, or a webcam. So they had to use their own equipment, their personal equipment. Also, there was an uncertainty with the coming of the COVID vaccines. The recommendations at the beginning were changing on the need for pregnant women to get vaccines or not. And there were so many informations going on in the media that the pregnant women felt very anxious and did not know whether it was better to get the vaccine or not. So there were many effects on women, on families, in the sense that they suffered psychological stress, they suffered anxiety and fear because of the uncertainty that there was around the whole process. Many women sometimes asked us how the moment of delivery was going to be. Very often the time of birth came and they didn't know where they should go, whether they should go to the delivery room or emergency room or whatever. And we professionals did not, and the healthcare professionals did not have the answers either, because we didn't know how the protocols would change until the very last minute. So this made us feel very frustrated because we're not able to give reliable information to women. We also saw that there were changes in hospitals and there was an ambience of mistrust and fear. We saw that we were fearful that we could get infected. We saw that our colleagues were getting infected and they were taking the infection home. So we saw that we had to change our shifts. We had to change the way of working. Midwives, since we are also nurses, certain hospitals decided to take the midwives outside of the delivery rooms and for them to go to emergency rooms. And we did not get any support by the administrations. We have seen that after all these 2 years have gone by, there has been no recognition by the administration to professionals that have really undergone very difficult times. I think that the healthcare professionals that have been there at the forefront, once the worst months have disappeared, I mean, we have had no kind of acknowledgement or recognition for the task we've done. Now it seems that we are going back to normal, and now we can analyze how all this has affected the maternity wards. We still have COVID protocols in hospitals, and this also affects pregnant women. There are pregnant women that feel anxious because they're fearful that they can be positive in COVID test at the time of delivery. Certain hospitals still limit the fact that the partners can accompany women during childbirth if they are positive in COVID test. In the case of women that are positive in COVID test, sometimes they have to confine in plans for COVID patients. Also, those that are not positive in COVID test, they fear they can get infected in the hospital. Also, this high interventionism that took place in the West times of the pandemic, then this means that many women think that they will not have a voice in the way they want to give birth. We have gone back to in-person consultations, but there are still some limitations. We have to consider the use of ICTs because actually they have become a very interesting resource for the population in general and for families, because the development of apps or professional channels that convey reliable information to citizens. I mean, this is a very effective means of communication between the population and the healthcare professionals. Although we are going back to normal, pregnant women are still very anxious about being infected. That is why they reduce their social contacts during pregnancy and the first months of life of the newborn. So normally, I mean, traditionally, maternity is lived in group with a whole social support, and now very often these women live maternity in isolation in a way. Also, I refer to maternity in general, that is before the delivery and after delivery. Certain families just say that, well, it's very well to have fewer people visiting them at hospital or at home, but in a way, if our society has been already losing the concept of tribe, supporting the new mother and the newborn child, this has been worsened with COVID. We have developed also the capability to work under stress of fear, I mean, healthcare professionals. And many of us have been affected by post-pandemic fatigue. As a means of reflection, how should we envisage the post-pandemic scenario? I think we should take this experience as learning in values such as resilience. Healthcare professionals have to take into account that there may be another situation similar to one that we have lived. We cannot forget what we have learned during this time in order to be able to be ready to apply contingency plans and to change our routines overnight so that we can actually care for patients. We think that nowadays there's no justification to maintain restrictions in accompaniment of women during delivery, after delivery. There is no justification for the separation of the mother and the newborn if the mother is positive in COVID test, taking into account that she is in good clinical conditions. There is no indication either, there's no justification to interrupt breastfeeding. In fact, there is evidence that breastfeeding actually provides the child with immunoglobulin, which is actually something positive for the baby. And in this scenario that we have lived, where we see that hospitals are actually cannot cater for all the patients, and so we think that now is the right time to establish. Midwives believe that we should build these what is called delivery houses in order to be able to care for women at time of childbirth in an adequate way. Thank you very much, Salomé Álvarez, for your presentation and for this view of professional practices in hospitals during the pandemics. We are now going to give the floor to the last speaker, Aranzazu Villar, who is a partner of Parto Nuestro, which is a non-for-profit feminist organization with users of the healthcare system, especially women and mothers that want to improve the care and attention to mothers and children before, during, and after childbirth. This entity was started in 2003, and since then they have been working from different fields and at different levels in order to contribute to changing the experience of childbirth. During the pandemics, several campaigns were launched. One of them is "Do Not Go In Alone," of which Aranzazu was responsible, in order to claim against the rights of the women to be accompanied in the important moments before, during, and after childbirth. Aranzazu Villar, you have the floor. Thank you very much. I was going to share the presentation, but there's something wrong with my computer. I'm just going to tell you about the results of the campaign. In the first place, thank you very much. And I want to thank the organizers for giving us the opportunity to tell you what the Childbirth is Ours project means. And of course, this was important during the pandemic, but also now, because we find women that actually undergo experiences that seem something of the past. So thank you for letting us contribute our experience. I was going to present what the Childbirth is Ours is. It is a non-for-profit organization that includes mothers and women that want to improve the conditions of attention care to mothers and children. The association was born in 2003 in order to help women that had suffered some, for example, cesarean section, unnecessary cesarean section, or traumatic labor. And this with a view to actually base decisions on scientific evidence. In order to talk about new horizons that we think are important to lay on the table, we would like to explain to you what has happened since the beginning of the health crisis in March 2020. We can say that when the crisis started, the association had a tsunami that actually collapsed the communication and the channels of communication that we had at the moment. It is true that at that time the association, the society at large, was affected by the emergency, the breakout of COVID. Everybody had to adapt. Salomé explained how midwives and nurses had to adapt. Everything happened overnight, and there were restrictions that we think were justified. But 2 years after the beginning of the pandemics, we believe that these restrictions are no longer justified. We think that pregnant women were actually suffered certain restrictions that did not adjust to scientific evidence or to the healthcare protocols. This crisis situation meant there was a violation of rights. There was an increase of complaints, questions to our association on care given to pregnant women and women at birth in both the private and the public healthcare sector. So this is a summary of what happened during the crisis. We would like to have in the future we would like to guarantee in the future a respectful attention to women when they give birth. and to make sure that their rights are respected in any situation. Since our association, we have conducted several campaigns in order to accompany women to file complaints and to advocate for these women that were affected by protocols that did not adjust to scientific evidence. The guide that Salomé has explained, well, this is something that we the guide, as she says, it was only recommendations, but we think that many hospitals actually did not implement these recommendations. At the beginning, as Salomé has said, no international organization or national organization actually took action. And we saw that many women had to give birth alone. In the Valencian community, really, there was a case that had a large impact. On the 4th of April, during confinement, the Valencian Ministry of Health said that all pregnant women were forbidden to be accompanied by their partners during childbirth. And this went against all recommendations by the WHO and all other protocols. There was no scientific evidence that justified this restriction, and the WHO, for example, recommended and still recommends, even in the cases where the mother is positive in the COVID test, that she should be accompanied during delivery. But this was forbidden in the Valencian regional community, as I said. This made many midwives associations and healthcare professionals in the autonomous region of Valencia and also associations of women, they all got together in order to complain about this restriction, and they lobbied so that this restriction was not implemented. There were many groups of our association that mobilized in order to create networks of support between midwives and other healthcare professionals. It was 4 days of very intense work. And the result of this was that there was a new instruction coming from the health ministry that actually changed the previous one and enabled and allowed women to be accompanied during childbirth. We have also seen separations of the mother and the newborn child, and this with no justification and no scientific evidence. And this still happens nowadays. For us, this is something that we want to claim for. The mobilization, joint work, networking can actually change the policies. So if there is joint work of midwives, women associations, and healthcare professionals, if with a joint work of all these associations, it is possible to revert these situations. But we still received complaints because the women said that they were alone during the follow-up of the pregnancy. The aim of our campaign is to actually know and visibilize this fact, the fact that the pregnant women cannot go to the medical consultations with the company of the person that they choose. This association and social networks, social media like Instagram, Facebook, etc. We conducted an interview to find out how these women had been taken care of during pregnancy and delivery. We also gave them a complaint form so that they could fill it up and file it in the necessary instances. So this campaign started in April 2021 through a questionnaire. On the 31st of May, that is 2 months later, we already had over 1,000 responses. Once we had gathered all the results and the conclusions of the analysis of the results, we saw that 1,300 women said that they could not be accompanied by their partners during pregnancy, and the rest of the respondents said that they had been accompanied in some tests but not others. 65% of women, of respondents, said that they could not have the company of their companies in primary care centers or hospitals, so in any healthcare premises. Over 200 hospitals of all regions also responded to the questionnaire or are present in the questionnaire. This affected women of all over Spain. One of the images that I would like to show you is a map that we call the map of shame, that shows that all of the regions in Spain were affected by these bad situations. That is to say, there were no hospitals, except for a few private hospitals, that allowed the women to be accompanied by their partners during the follow-up of the pregnancy. The situation has worsened in these 2 years. So several speakers have said that we have to recover certain rights that we already took for granted and that have disappeared completely. I want to mention another side effect that we are also denouncing, which is the shortage of midwives. The women that were studied to become a midwife, they had to interrupt their internships. So this means that these women are not going to have their degree until much later. This was a situation that was already known, and there has been no contingency plan implemented. There has been no statement by the health authorities. So we have a shortage of midwives. This means that the future will be difficult. So 2.5 years after the beginning of the pandemics, this is the situation that will have negative effects for pregnant women and for midwives. So we have to make sure that even that after the health crisis, we make sure that women have their rights, do not have the rights violated during delivery. And I'm going to show you the map that I mentioned. See if I can share my screen. These are some pieces of news regarding, for example, what happened in the Valencian region, that is in the east of Spain. There's a podcast on this issue of what happened in these 4 days of mobilizations, if you are interested. So what happened since in these 4 days of mobilization? This is the campaign, the image of the campaign. Don't go in on your own. This is the image of the campaign. And here you see the map that I wanted to show you. As you can see, there was no single hospital in Spain where a woman could go accompanied by her partner. And also, as I said, one of the problems now is that there are no midwives. Thank you very much for your attention. Thank you, Aranzazu. I think in this roundtable, we have seen different profiles and different perspectives from the different professional profiles and also women's association. Do you want to debate amongst yourselves, or do you want to ask some of the questions that you yourselves have launched? For example, Salomé, maybe you want to mention something with regards to the shortage of midwives.
Realmente es verdad que el COVID quizás ha sido la gota que ha colmado el vaso en este sentido de la falta de matronas, porque
maybe the COVID has been the last straw because this lack of midwives and for midwives, it's not that they're going to have longer qualifications, but they're going to start later. So that COVID made it worse. And we see midwives in acting as nurses in COVID wards, etc. And I have to say that in general, they gave everything back, everything up in order to recover their qualifications and recover them professionally. They try and do their best, of course, but the lack of midwives is something that we've been warning about since 2014, I think, was the first time we sent this report to the Ministry of Health, this lack of midwives in Spain, with a very serious problem that we would be facing in 2020. There was no guarantee to follow them, those first ones, because there was no renewal, no new ones who would take the qualifications, and not enough of them are being trained professionally. From within the Federation, we've been asking the ministry for the number of seats to train midwives to be increased. We haven't achieved it yet so far, and we'll continue insisting. And the problem that bothers us or affects us most is that they still send us back to the giving birth wards, rooms, to keeping that role. And so it's exhausting to always having to face up to professionals or different political profiles, and they don't really understand the competencies and abilities of a midwife, which means that sexual and reproductive health or rights of women don't really know what this is about, and whoever is organizing all of this is not aware that there's a full network. The implications are huge, and what I'm afraid of is that in the 21st century, women's health is really not something that is a worry, or it's not something that society worries about, rather. About questions, while those are being listed, I'm going to raise a question to the three speakers to start up the debate. So here it goes. Looking at the future from the fact, no understanding that the pandemic reversed the reproductive and sexual rights of women, from the lessons learned, and looking at the future, what spaces can we build together, all of us together, to rebuild those rights? What alliances are necessary to look at the future and make a note of those lessons learned? If there are any other questions, but I'm raising this one to warm things up a little bit, if I may say so. I would like very briefly to say there is one option that has started getting into practice, and these are the birth centers, whatever way you want to call them. And it is important to remove the link between pregnancy and giving birth to the pathology department of a hospital. It is true that pregnancies and births were introduced in hospitals in the 60s and 70s to reduce children's deaths, but they've turned into pathologies. There are very normal pregnancies, low risk pregnancies with no pathologies, and they should be taken care of by professionals in centers that provide security, but not necessarily a hospital. But we've come to understand during the pandemic that it is time now to develop such spaces where we can see to healthy people in a non-hospital context. So there. I'm going to answer one of the questions you've raised, and Salomé also said the pandemic also brought in fear, lots of individualistic onlook, not so much being a part of a tribe. And on behalf of the association, I would say for people to be part of an association, build up the effort as a community and raise our voices, because in some areas, in some territories, they've progressed more, but there's a lack of a democratic input or taking part. And instead of complaining, but if we, instead of that, we got together, got united, became part of an association, we were to state what we want and perhaps prepare for new crises in the future or new pandemics, not to be alone, not to end up being alone, and to be accompanied and get the support in the Valencia area where so many voices were raised from our association, from midwives raising their voices. The protocol eventually was changed. So I think there's a lot more to be gained from being part of a community. Helen, would you like to add anything to what is being said? Helen also said that there's lack of midwives.
Yes, there's very lack of midwives in Sweden, but we have continued the program for midwives during the COVID pandemic. So the midwife students were allowed to be at the hospitals. So that was good. But actually, that is it's for 1.5 years, and the midwives that graduated this January actually had all the lectures on Zoom, and then they had the practice in the clinics, of course, but it was very strange for them, but they did it, and it turned out well. So, but we have a big problem in Sweden because many midwives have left the hospitals. And now in Gothenburg, I think we lack about 100 midwives at this big clinic where about 10,000 women give birth every year. And now the organization really have plans to do it better for midwives, for working conditions, and to promote normal births. But now we must have midwives, because otherwise we can't do the plans. We can't do anything about the plans. So it's really like, moment 22. Have you heard about it? We need the midwives to do this new plans. One of them are if midwives want to work with the women all the way from the pregnancy and then take care of them the delivery ward also. There is a project like that in Stockholm. It's called My Midwife. And then there is a group of midwives that take care of the women. And one of them will actually be there with her at the labor ward. And I think this is also done in Denmark. And we also have a big study in Gothenburg, or all over the country actually, for induction of labor, where we will include 8,000 women, and half of them will do the latent phase or the induction at home. And then we can leave the hospital, the ward, to the women that are in active labor. So that is something that we do also.
Mm-hmm.
But it's a very, very, very big problem that the experienced midwives, many of them have retired, and there are very many new midwives, and they think it's too stressful, so they quit the job.
Mm-hmm. Thank you. And we have one question from one participant from you, Helen.
Yes.
It's about the comparative study with several European countries. And
Marta, perdona, recuerda que hay traducción simultánea
vale,
en castellano para no distorsionar los canales de idiomas.
Sí, es verdad. Es que me salía mal hacer una pregunta directa.
There is, interpreting. There is a question to you, Helen, about the comparative European study that you presented during your presentation. And you're asked whether you could expand what you say, the data, specifically what could be relevant to Spain, because you said Spain was
yes, Spain
had
was,
a good
yes, Spain
marks.
was in the big study. I reported about a part of the big study with 5,000 women from Sweden, but actually it was about 21,000 women, and I think it was 350 from Spain actually. So the results are in the publication in the Lancet Regional Health, so you can read it there. And also we are continuing to recruit women for this big study, so there will be more papers, and then maybe Spain will have more women in it. We will also present a cross-sectional study on healthcare workers' experience of the care. So that will be published maybe this autumn or next spring or something. So that will be another side of the problem. But if you would like to have the more details about Spain, you can read the publication, the Lancet Regional Health.
Thank you. Procedemos. Hay varias preguntas también para.
There are several questions for Aranzazu and Salomé. I don't know if Patricia wanted to manage and raise those questions. Yes, I saw one have the results of Entresola been published. Yes, they have. In the website of El Parto Nuestro, you can see the results with the presentation, the map. There's an email address too, but it's a draft report with the results, with the answers that we've provided for those months to those questions raised. Thank you, Salomé. There are several questions about what has been published as for recommendations or directives applicable to women that didn't test positive and that would have a companion in the hospital, even if that wasn't allowed. What happened in those cases? Could you, were you able to read those questions, Salomé? Yes. The recommendations at first were appearing on a daily basis and they were changing on a daily basis. But it is true that the WHO and the ministry were quite clear about their recommendations from the start. All of those recommendations were accessible to everyone. And so for the health systems in the different regions of Spain and at each hospital for the micro management, of course, each center established their own protocols. I work in a small area where we have 8 birth rooms and we all had different ways of operating. So how could we get such recommendations to reach the citizens? To me, as the Association for Midwives, we published notices explaining the evolution of such protocols and as per these birth centers. But in general terms, because each particular situation was different according to the area of Spain, and sometimes it turned out to be very difficult. It is still very difficult to provide real information as to the way care is given to COVID cases because there are still COVID protocols. So it's still difficult to find the general rule for what's being done. So this helps us understand what healthcare staff have lived in the last 2 years to provide peace of mind to the majority of our women, because that's not the case in many cases. One of the questions was, what happens if you let a companion get into the room having tested positive? Well, most likely there were problems in the birth rooms in hospitals, but I don't think this has gone has not progressed. At work, we have to follow the protocol of the hospital. A protocol will have been made up based on scientific data and mustn't contradict with what evidence tells us. In spite of that, we don't have written protocols not allowing someone to get into a room, but we had to face personal circumstances because that companion into the room would not be permitted. If that had gone to more serious circumstances, if there had been a claim against the midwife not allowing for the companion to get in, I don't think there would have been much of a criminal path to that, because there are legal terms that back this recommendation up. So in principle, we are backed up, but the stress and strain in hospital centers, in healthcare centers, in the end made for everyone not to clash against anyone. And perhaps we would have been more strict against those people who didn't make things easy. But I must say it wasn't easy. I'm talking about the bathroom where I was in, but any healthcare member of staff could confirm this. It wasn't easy. Every day was new, new circumstances. We didn't know what we had to face up to. And I want to think that the majority of us tried our best and many times also probably didn't do it rightly. And I'm talking about 2020. Nowadays, this would be unacceptable, of course, not to do it rightly. And I had read more questions whether the Federation had been able to speak to the government and what was our perception against sensitivity towards giving birth. Yes, we have talked to the different ministries, lastly to the health ministry, to equality, to the equality ministry, and according to also the latest law on sexual and reproductive rights. Also, it seems there is some sensitivity, but I'm still waiting for this to become a practical matter and not just words and good intentions. I'm wishing for these good words and intentions do become and appear on our table for once and all. The intention is a good one, but making it a fact, it doesn't seem to be as real. I'm not sure if I'm forgetting anything. There is this other question for Aranzazu. For Latin American countries, it is difficult for families to report. How can we promote or induce people to make a claim or report? Our birth is, our association is present in Ecuador and Argentina, and nowadays we have the social media, of course, that help us pass on a message, and perhaps what's happening to you on your own is happening to someone else, and perhaps raise our voice that way. And this is what comes to my mind. Why don't we, as a society, don't do anything about this? And perhaps we should try and find the answers to why we don't participate. We're not taught to do that and to be part of a participatory democracy. For now, we need to find people in our networks, in our social media communities, or neighbors, female neighbors that are going through this. But a lot of the questions that we are asked are not asked until they've given birth, and they don't want to report this until they've given birth because it's not easy for them. Thank you, Aranzazu. I was told that there was one more question for Salomé. I think that she partly answered it, but I'm showing it to you on the screen, whether the Ministry of Health published all other protocols or measures for women who didn't test positive. So if their rights were protected while being pregnant or after the pandemic, what recommendations did the healthcare staff receive at those times? Of course, the recommendations from the ministry obviously were addressed to pregnant women having tested positive. So obviously those who didn't have COVID were not affected by any other measures other than those of the hospital per se. But for those women that were in the hospital, the personnel not only reduced, but took out, removed all potential visits. These women were at a maternity ward, of course, but in many hospitals, these women could not give birth with a companion because companions were not allowed within the premises of that ward. So the ministry didn't say much at the time. It was included, or they were included together with the rest of patients who were suffering from this social isolation or lockdown. And to our women, of course, it wasn't good. As for the rest of the hospital patients, it wasn't the best. These weren't the best measures taken during those times. Some efforts were made to spread the measures. The efforts within the Association of Midwives were made because up until today we still have centers that are not working as they should, because there's no justification to separate the mother from baby, etc. And other things that were done during COVID times. We try and spread this out. We try and spread it out from within the association, but that's it. If there are any other recommendations from other entities, I'm not sure about. It is the midwives associations and women's associations that do produce these recommendations. The recommendations that we receive as professionals formally stated as to wear or not to wear PPE, sorry, or to not have contact with the patient. Is just that everything happened so quickly that I think the healthcare staff came out not bad at all in the end out of all of this. I think that I don't know if there was too much or too little information. I don't know what's the end of it, but it wasn't, of course, explained well to the group of pregnant women. This disease wasn't explained properly. The repercussions and how they could be infected, and the staff also wasn't informed properly on how to protect ourselves while carry on working in the most professional and recommended manner. This is what I would say as a professional. This is a professional reflection. It was let's run as fast as we can, but we need to work and provide good quality work and get back home being healthy, because we were surrounded by people who were afraid of that. So I hope we do not have see such a scenario again
in the future. Thank you very much, Salomé, for your explanations. I don't know whether any of the speakers want to add something. We are about to finish. We have a few minutes left. So if anyone else wants to take the floor. Then we're going to give the floor. Helen wants to take the floor. Yeah.
I can see that it's quite the same, but in Sweden, at least, we let the partners be with the woman at the delivery. So that was some difference, but otherwise, I think it sounds like we have the same situation. Thank you.
Thank you.
Pues, Marta, entiendo que das por cerrada la mesa.
Sí, Sandra.
So, Sandra, I give you the floor for you to round out the session. I want to thank the speakers and all the participants that have contributed their questions. And now we are going to close the session. So I'm going to give the floor to Sandra so that she wraps up this seminar. Thank you, Marta, and thank you all the speakers of the first and second roundtable. I'm not going to open new debate, but regarding to what Salomé said, so what efforts were made from the public administration. Of course, the spreading of the information had to be done from professional associations, because you also have the capacity to reach everybody in your sector. There are, because of course, a Minister of Health or Minister of Equality cannot say certain things, and so the work of the association was very important. Salomé said, was there too little or too much information? I think that the word is confusion. There was a confusion of information, and this is a means of reflection, and also because they were very complicated times, because Salomé, you said that many people did not want to report. They wanted to wait until after delivery. And here we cannot lose sight of the vulnerability of people during pregnancy and childbirth. I was a mother in May 2020, and I lived many of the things that you are explaining here now. I felt anxious at the moment, and the activist me did not come out because I was so worried, and I had so much anxiety. I didn't want to make anyone angry with me. I just wanted to, I felt so fragile and vulnerable that I just wanted everything to go as smooth as possible, and I did not want to report anything. So it was very difficult to have information that enabled us to live our maternity in a more calm way. So I think that the lack of information or the confusion of information actually contributed to increase anxiety and fear. I think that many of the things that have been said here are very important. I loved this interdisciplinary approach and dialogue amongst the different professionals of these inter-alliances, I would like to say. And just, if I want to give you a headline, Marta said in the first roundtable that this effect of having gone back, but not to, I mean, everything that we have fought for from the feminist movement, from professional associations, from researchers, it seems that we have gone back in time, and this can have devastating consequences. I think that this has happened in many fields. For example, in the homes for the elderly, in the treatment that the old people have received and are receiving. So Marta said that this has happened because the rights were not well consolidated. For example, the idea of houses for delivery. I mean, if the system does not believe in that the guarantee of certain rights for women, that it's necessary to guarantee this, right? So we need to consolidate the rights so that they are not violated when a crisis arises. But I think that especially at times of crisis, it is especially important to actually respect and guarantee the rights. Something that many of you have mentioned and that I find very interesting is the idea of individual responsibilities. Since there was a lack of resources and a lack of response by the health system, then very often it is the individual woman that is giving birth, the one that has to take decisions. So this idea, if you think of the image of a woman giving birth with a mask on, this is a metaphor, I think, since there is a lack of resources and instructions from the system, then the individual woman at a very vulnerable, fragile point in her life has to actually take decisions. And this is applicable to other sectors. For example, or to other situations, for example, the visits, these medical consultations after, during the puerperium, the women, instead of going to see the doctor, the midwife, for them to actually do a physical examination, then it was women themselves that had to decide whether, for example, the stitches were healed correctly or whether the baby is actually breastfeeding correctly, whether we do not have this knowledge. So again, the women themselves have had to be responsible individually for their health, whereas it is the public health system that should be the system that guarantees our health. I think you have shared very interesting data from, for example, this idea of seeing the hospital as a safe space or not, and how, as Josefina explained, the whole history of hospitals, or the data that Marta or Aranzazu contributed on the gathering of data from their association. These are data that should be produced by the public administrations, and they are not being produced. And it is associations that have to researchers that have to produce this data. The public administration, in a way, are resourcing to universities and research groups and entities in order to obtain data that they should have generated themselves as a part of public health policy. Because, of course, you can only take political decisions if you have the data that actually justify the decisions you take. I also found it very interesting, the idea that Salomé contributed, that very often from the point of view of the feminist movements, it seems that the emphasis has been placed on the impact on pregnant women and on the newborn, but we cannot forget the impact that all this situation has had on the health professionals, on midwives and nurses, because sometimes you have had to use your own common sense and to attach to your own principles in order to respond to individual situations. And it is not only women, but also the professionals that maybe they have felt vulnerable when the hospital gives them some certain orders, so to say, instructions that go against their principles. So the midwife is a profession that was very important many years ago, and in a way there has been this sort of male technical view of what childbirth is, and it is important to actually see again maternity from the perspective of midwives and from a more feminine perspective. So this figure of the midwife that symbolizes what I'm saying, well, it is a real problem that there is a shortage of midwives, whether it is in Spain or Sweden or any other countries. And this is not just a problem because you cannot give you cannot care for all the women that need them, but it is also a symptom that the rights of women are not well understood from the political stances. And it is important to raise our voices and to echo the need of having more midwives, because people that are responsible for health systems really are not aware of the bad consequences that the shortage of midwives can have for women giving birth. And of course, you have all mentioned that there have been certain interventions or instructions that restrictions that have been imposed without any scientific evidence. And this is something that we cannot forget. In fact, public policies or public health policies actually, it's difficult to I mean, they should take into account scientific evidence before they impose any restriction or give any instruction. It's difficult to sum up everything that has been said because there have been so many interesting contributions. It is quite clear that more work needs to be done. It is important to actually generate knowledge that is useful and that is at the service of women and with the will of transformation. And maybe, as Aranzazu said, we have to raise our voices in order to improve the situation. I want to thank all the participants and all those that have contributed to your reflections and questions. I want to especially thank the speakers because of your speeches and the whole team that have made this seminar possible. If you need any attendance certificate, we can provide them, and we will also reach all of you for you to receive a summary of the conclusions here, because this seminar, apart from it being a training session, we hope that it should have as a result a serious, it should contribute to generating a tool that can improve the construction of alliances in order to work together to improve the respect of the rights of the women. I have not mentioned that Josefina is part of this chair. The UNESCO chair comes with the participation of the Uvic-UCC and also the University. So we'll keep in touch, and I hope that we can meet again to continue learning from each other. Thank you.
Y también agradecer a María, Ruth y a Dani. Que
we also want to thank Maria and Ruth, the interpreters, and Dani, the technician, for the help, because they do not have the cameras on, but they have made it possible for us to communicate into different languages. Now this is a difficult task, and also, Dani, we thank you for your technical support.
No sé si Patricia, Monse,
Marta, is there anything that you would like to say before we actually close the session? So I would invite the participants to leave the session. I want to thank all the speakers for having contributed their knowledge and for sharing all these experiences. So I think in this sense, the seminar has been successful. So we have seen a 360-degree vision of what COVID and maternity has meant. It's been a pleasure to listen to all of you. And also thank you for all the participants that have been listening to us. Well, we have become so used to these virtual seminars, but of course, these require an added effort of concentration, being for 3.5 hours watching a screen. This is something that is sometimes difficult and it needs a lot of concentration. So video conferencing actually has certain advantages, but of course, it also has the disadvantage of having to be paying a lot more attention. And no applause at the end of the seminar, which is something that we miss. I also want to thank all the speakers. It's been super interesting.